Sure. So I started off as a software engineer many years ago and was co-founder and CTO of several failing startups in the early 90s. And at some point, I had enough of the startup world, vowed never to do it again, and went to medical school. I was the oldest medical student in Tel Aviv University at the time, graduated, specialized in internal medicine, and later having executive roles in one of Israel's leading hospitals. In parallel, I did a PhD in computational biology. I teach medicine. I practice medicine. These are the things I really like. And in the last few years, I'm CEO of a company named Medaware. And the idea behind Medaware came purely by chance. I never expected to go back to the startup business after I vowed never to do it again. But a few years ago, here in Israel, a 9-year-old boy died simply because his primary care physician clicked on the wrong entry in the put-down menu list of the medications and prescribed the wrong drug by mistake. There was no contraindications, there were no dosage, no interaction, just simply the wrong drug for the wrong patient. And one would have thought it would be some kind of a cool spell checker to prevent these typos from happening, but apparently this did not happen, and the boy died a few days after taking the medication. Now, when you think about the tragedy, it wasn't bad judgment, it was a typo. And eventually typos kill in medical practice. So I decided I should do something about it, and here we are today. So going back to the story that actually initiated the company, just wrong drug for the wrong patient. So how would you identify that? I mean, you could write rules that say don't give this with that, but it would be endless, right? Like 2,000 different medications, just the combination, you're reaching millions. So how would you know what is normal and what is not normal? Or what is an outlier in terms of the relevance of that medication to that specific patient? So with the use of artificial intelligence and statistical methodologies, it is suddenly possible because we can harvest millions and millions of electronic medical records, analyze them, and let the machine, the AI engine, basically learn what are the normal patterns of prescribing and identifying outliers as potential risks. So in the example of the boy, he received anticoagulation, a blood diluter, instead of his asthma medication. Now, if you look at the patients who are 9-year-old at, I don't know, the pediatric clinic, and you look, what is the likelihood of them being prescribed with anticoagulation, the chances are very, very, very low. Look at the flip side and see what are the characteristics of the patients that are likely to receive anticoagulation. So mostly are older people with cardiovascular problems, maybe have some lab tests or specialty visits, clues that would give us a hint that they may or are likely to receive anticoagulation or blood diluters. And this 9-year-old boy, which is practically healthy, is again an outlier to that population. So we can see on different dimensions that medication, not even clinically, but statistically, is an outlier relative to the profile of that patient. And this is again based on analysis of millions of patients similar to that boy. And this was the foundation of the company. This is what we have started with. And along the way, we have developed more and more models that are able to detect different kinds of errors. So we basically started by thinking, how clinicians make error? What is the mechanism of an error? So one mechanism, like the one, choosing the wrong drug in the wrong, in the pull-down menu, just clicking the wrong button. So we built a model for that. And then we said, okay, but in the EMR world, the physician can give the right drug to the wrong patient just by being in the wrong file by mistake. So build a model around that. And then we dove into identifying maybe adverse drug events, maybe contraindications, maybe monitoring the patients throughout the duration of treatment and trying to identify different risks along the way. So suddenly we became from a company that develops point of care decision support that at the point of prescribing to basically monitoring the patient profile throughout their duration of treatment or lifespan, looking continuously and actively for errors or for different kinds of risks that may emerge later on. So an example would be if a physician prescribed a medication which was perfectly good for that patient, and the prescription was for a month. Maybe 2 weeks later, that patient underwent a lab test, and that lab test result made one of the medications contraindicated for that patient. So today there's no mechanism to connect it because the patient is out of context, he's not in the physician's office, and the lab test was maybe ordered by another physician and not the physician that prescribed it. But we're able to match all these data points and understand that we have now a risk. Question is, what are the workflows that need to support that this risk will be mitigated? But that's a second level problem. The first level problem, how to identify that risk, and this is basically what we're doing. So let's start with the second part of the question, and this is something that we actually examined in an academic publication that was published, I think, 4-5 months ago in the JAMIA, Journal of American Medical Informatics Association. So there we talk about thousands of physicians that prescribed 1.6 million prescriptions in a tertiary, very large academic medical center. And we basically used our system as a surrogate marker for errors because we know we're very, very accurate in a retrospective cohort. And then we measured what is the burden, work burden, sleep deprivation on that physician and lack of experience. So not surprisingly, we found that the more shifts, continuous shifts the physicians are working, the more workload there is in a specific shift, the more likely that these physicians will prescribe erroneously. Not only that, we found that physicians that are prescribing the medications that are not used to prescribe for the first time have also tripled the likelihood of erroneous prescribing. And this is aligned with other published data. So this is not new, but we're the first that published it at scale of millions of prescriptions. Now, this is anyone who underwent residency or went into the ER at 3 o'clock in the morning, sees the doctor, he definitely understands the situation. You don't want the doctor to treat you at 3 o'clock in the morning after you didn't sleep for 2 days. But then came COVID. And with COVID, two things emerged. First of all, the workload is tremendous, especially in last year during the escalation of the pandemic. You know, ERs were overflooded, ICUs were overflooded. The nurses and physicians and technicians and pharmacists basically are working to their limits around the clock. All the catastrophes waiting to happen and then some. And then you put on top of it repositioning of physicians into places where they're not used to be, prescribing medications that they're not used to treat for COVID and others just because of lack of manpower. And then you get the perfect recipe for catastrophe. And we don't have data on the magnitude of that catastrophe yet, but I'm sure that it will come out because anyone who's been there can tell you lots about it. So there are two components to it. One is, again, well documented, is that many of the current decision support tools, not only the electronic medical records themselves, but the current decision support tools that were built to help physicians and save them from making mistakes are doing the opposite in many cases because of high alert burden, reaching 20% or more of prescriptions that are being flagged by the drug interaction databases, allergy checkers, etc. While more than 95% of these alerts are false alarms and completely disregarded by the clinicians, and this calls for alert fatigue. And if you take a physician who didn't sleep for a few days at 3 o'clock in the morning, he would never listen to it. So basically, they are not saving the physicians, they're adding to their fatigue and basically preventing them from any ability to really capture the errors in time. Now, if we eliminate that, if we take this out of the equation, well, it won't give them hours of sleep and won't replace the electronic medical records vendors, but taking that buzz, that noise behind their heads, the hundreds and hundreds of false alarms every night out of their ears and putting high quality alerts only when it's needed, once a day, twice a day, only where some real catastrophe happens, then suddenly the stress and anxiety and the disbelief is significantly diminished. So that's one part. The second part, that's regarding the fatigue of the physicians. But the second part is reducing erroneous prescribing. Is we have seen that once we are reducing the number of alerts by a magnitude and enhancing their clinical relevance, suddenly it's not white noise. These are bleeps that physicians and clinicians actually respond to, and by that we can prevent error. Because even if you're giving perfect alerts that nobody listens to, you've done nothing. The only real measurement is how did you change the practice of the clinicians following the intervention that you made. And we know that, well, in almost half of the cases, physicians change their prescribing following the alerts that we provided to them, even in the middle of the night. And by taking these two approaches, reducing the number of alerts, reducing the fatigue of the clinicians on one hand, and enhancing the clinical relevance and accuracy of the interventions, so physicians actually act upon it, then you get a win-win situation. And this is how we approach that problem. So I just want to touch on the huge problem of opioid dependency, which is a huge problem in the US and also around the world now going down. And we see that although we are mostly concentrated around the patients who are at high risk of overdose and really trying to wrap them around with healthcare services and really identifying them, they're basically only the tip of the iceberg. These are the ones that are going to collapse soon. But for every patient with opioid use disorder which is diagnosed, there are at least 3 more that are underdiagnosed and many more that are on the verge, that are not at risk of dying tomorrow, but the levels of opioids that they're taking are driving them to lose their families, lose their jobs, get involved in car accidents. And these are the patients that we are trying to target and even prevent. So, and the secret is identifying the risk of the future risk of the patient for dependency before the first opioid prescription is provided. And by doing so, providing with a prescriber who may be an innocent bystander, an ER doc that just finished school or something like that, with the insight that said, hey, this specific individual is of high risk of future dependency if you give him this prescription now. So either choose a non-opioid medication, maybe reduce the dose, maybe call him in for a follow-up next week and not next month, just to make sure that he's well. And by providing these tools to the clinicians, we're empowering them to reduce the overall number of dependencies and battle this terrible epidemic while it's around us.